We've got a clinical case, my beloveds. Let's go. 32-year-old lady presents with a history of 3 consecutive spontaneous miscarriages. 3 consecutive spontaneous miscarriages. 32-year-old lady. In the first trimester, she also reports a past episode of deep vein thrombosis after a long flight. Laboratory studies show a prolonged aPTT, but her platelet count is normal. And she has a positive anticardiolipin antibodies on 2 occasions, 12 weeks apart. What is the most likely syndrome? Okay, give me the options. Von Willebrand disease, Antiphospholipid syndrome, that is disseminated intravascular coagulation, DIC, no. Systemic lupus erythematosus, no. Antiphospholipid syndrome is correct. So let's break down. Why other options are incorrect. Von Willebrand, of course, in this case it's incorrect. Von Willebrand disease is a bleeding disorder, not a clotting disorder. It's caused by deficiency of dysfunction of von Willebrand factor, that's why the name, which helps platelet sticks to damaged endothelium. Clinical clue: patients with von Willebrand have easy bruising, nosebleeds, heavy menstrual bleeding, and prolonged bleeding after surgery. But no thrombosis in pregnancy, thrombosis or pregnancy loss. Lab findings: prolonged bleeding time and aPTT, but no von Willebrand, but normal platelet count. Still, the key symptom is bleeding, not clotting. So while both antiphospholipid syndrome and von Willebrand can have prolonged aPTT, their effects are opposite. Antiphospholipid syndrome causes clotting, von Willebrand, yes, cause bleeding. Next, DIC, disseminated intravascular coagulations. It's not funny, huh? Actually, it's funny. So, DIC is a secondary acute systemic condition in which widespread clotting leads to consumption of platelets and coagulation factors, my beloveds, causing both thrombosis and bleeding. It usually occurs due to sepsis, trauma, malignancy, or obstetric complications. Lab data: prolonged PT and aPTT, low fibrinogen, low platelets, and elevated D-dimers. In DIC, So clinical picture in disseminated intravascular coagulation: bleeding from venipuncture sites, petechia, organ failure, not just miscarriages or single thrombotic episodes. Our patient is normal platelet count and isolated thrombosis plus pregnancy loss. Rule out disseminated intravascular coagulation. Actually, resembling, Lupus, systemic lupus erythematosus, incorrect. Systemic lupus erythematosus can cause secondary antiphospholipid syndrome, but it's a multi-system autoimmune disorder. Actually, both are autoimmune disorders, but features I: malar rash, no butterfly rash, arthritis, we'll talk about lupus, renal involvement, proteinuria, lupus nephritis, psoriasis, and central nervous symptoms. Lab data: positive ANA, anti-dsDNA, and low complement levels. The patient, our patient, here does not have any systemic lupus features, only thrombosis and pregnancy loss, consistent with primary APS, antiphospholipid syndrome. So antiphospholipid syndrome is correct option. Core features: arterial or venous thrombosis, pregnancy morbidity, recurrent miscarriages, stillbirths, preeclampsia, presence of antiphospholipid antibodies, anticardiolipin, lupus anticoagulant, anti-beta-2 glycoprotein 1, and paradox: despite prolonged aPTT, patients are hypercoagulable because antibody activate platelets and endothelium. Good question, huh? Yes, stay blessed.